Retroperitoneal Sarcomas, a Surgical Challenge, by Professor Dr. Zahid Mahmood, Professor of Surgery, LMDC and Gorky Trust Teaching Hospital, Lahore. What are retroperitoneal sarcomas, RPS? Retroperitoneal sarcomas are rare malignant tumors arising from mesenchymal tissues in the retroperitoneum. They constitute about 15% of all soft tissue sarcomas. The most common subtypes include liposarcoma, leiomyosarcoma, malignant fibrous histiocytoma, also known as undifferentiated pleomorphic sarcoma. Why are they challenging? These tumors often present late because the retroperitoneal space can accommodate large masses before symptoms arise. They can reach sizes over 15 centimeters and may encase or displace vital structures such as the kidney, aorta, inferior vena cava, ureter, and bowel. Recurrence rates are high due to difficulty in achieving complete surgical resection with negative margins. Clinical presentation. Most patients present with a painless abdominal mass. Other symptoms may include early satiety, constipation, dull pain, weight loss, or lower limb swelling if venous return is impaired. Diagnosis. CT scan with IV contrast is the investigation of choice. It defines the size, extent, and relation to adjacent organs. MR may be used for better soft tissue contrast or assessment of vascular spinal involvement. Core needle biopsy under imaging guidance is preferred for tissue diagnosis before considering neoadjuvant therapy. Open or incisional biopsy should be avoided to prevent tumor seeding. Staging. Staging is based on tumor size, histological grade, depth, and presence of metastasis. Metastasis is less common at presentation, but should always be ruled out with CT scan of the chest. Treatment strategy. Surgery. Complete end-block surgical resection with negative margins, R0 resection, is the cornerstone of treatment. This often involves resection of involved adjacent organs such as kidney, colon, pancreas, or spleen. Achieving an R0 resection significantly improves long-term survival and reduces recurrence. Radiotherapy. Preoperative radiotherapy is preferred as it reduces tumor size and the risk of intraoperative tumor rupture or spillage. Postoperative radiotherapy has limited use due to retroperitoneal toxicity. Chemotherapy. Chemotherapy has a limited role in most retroperitoneal sarcomas. It may be considered in high-grade, metastatic, or unresectable tumors. Prognosis and follow-up. 5-year survival rates range between 40 and 60% if complete resection is achieved. Recurrence is common, especially locally. Regular follow-up imaging every 3 to 6 months in the first 2 years is essential to detect recurrence early. Practical points for PGRs and HOs. Always consider RPS in patients presenting with painless, deep-seated abdominal masses. Avoid open biopsies. Use core needle biopsy only when necessary and under image guidance. Surgical planning should be done in a multidisciplinary setting at specialized sarcoma centers. Surgery remains the only curative treatment, and aggressive resection is often required. Professor Zahid Mahmood's comment. Managing retroperitoneal sarcomas demands oncologic discipline and anatomical bravery. Clear margins matter more than preserving organs. Plan, prepare, and operate with confidence. Clinical consultation. Gorky Trust Teaching Hospital, Tuesday and Thursday, 9 a.m. to 1 p.m. Hameed Latif Hospital, Monday to Saturday, 6 p.m. to 8 p.m. Contact 0300 41 30159.